So we can
Okay.
even break that down. But the bottom line of eye movement desensitization and reprocessing is that there's a theory. So this is not the theory.
Yeah.
It's the therapeutic modality, but the theory that underlies EMDR is called adaptive information processing.
Okay.
And it sounds fancy, but what it means, it's actually super cool when I think about it, that human beings naturally are inclined toward healing
Okay.
given the right circumstances.
Welcome to Take Three and Call Me in the Morning, a podcast where three doctors from three different disciplines cut through the noise and bring nuance and practical insight to conversations about health that actually matter in our day to day lives. I'm Vahid, a physician, and I'm joined by Pega, a doctor of clinical psychology, and Adam, a doctor of physical therapy. We bring our perspectives together to connect the dots and tackle the questions, trends, and everyday issues that can leave people unsure of what to believe or what to do next. No gimmicks, no fads, just real conversations grounded in evidence, experience, and a dose of common sense. All right, welcome back. We are here today to talk about therapy. Um, in a broad and general sense, and you could not be more excited, Pega. We're laughing because Pega was just saying how it might seem boring to people, but I'm saying no, and I think most people that are listening would agree that we can learn a lot. So um, I would say the vast majority of people probably don't realize how many different types of therapy there are, or like what they might be useful for, what they're used for, and things like that. So I was hoping that this episode would be an opportunity for me to just ask a bunch of questions because I don't know enough about the broader different therapies outside of a few well-known ones like cognitive behavioral therapy, for example. So why don't we just jump right into it since you are so excited to talk about it?
So yeah, so when we go to graduate school, we tend to study what's called theoretical models. So there are theories, right? So the theory behind why a person is struggling with depression, the theories around why folks might be having anxiety disorders. So what you want to kind of do is like kind of start there. Like what I feel like sometimes the question of the problem comes first, and then the theory behind why it is the way it is comes out of that. Make sense?
Yes.
Um,
So, I mean, for example, let's say I'm somebody who has maybe some type of anxiety disorder or some kind of depressed mood or major depressive disorder, and I say, okay, I've been told that I need psychotherapy, so I'm gonna go through my insurance list and see who offers psychotherapy. Blah blah blah. Blah. Okay, hi, I'm suffering from anxiety, depression. um, does that therapist then go, okay, let's see what you're dealing with, and I'll choose which type of these therapies would be useful? I mean, could you walk me through? And please,
Sure.
I'm very ignorant about all these, so walk me through. Like, is there like a basic group of types of therapy that every psychotherapist has to be trained in, or do you get to like super specialize into a couple of these and only do that type of therapy? And how does that work when somebody's seeking you out? Or just,
Right.
yeah, if you wanna
Yeah.
walk me through that a bit.
Yeah, I think so. That's I think a bit of a better way of looking at it is what does the therapist or the clinician specialize in? So what tends to happen, at least for me, as in my track as of becoming a psychologist, initially we get sort of trained broadly. Here's all the different theories of psychotherapy, and we get some background in general human development, what we call maybe lifespan span development. I think they call it something different today. We get a little bit of the what is it called? Physiology of usually the brain. So there are some things across the board. We learn about cognitive development, how memory, um, language development, learning, the different learning styles. So this is kind of what grad school kinda looked like for me.
Okay.
Um, then, yes, we go into different classes where we get very specific training around the types of therapies. When I was coming along, it was mostly 2 camps: cognitive behavioral therapy or therapies, and then, um, what I kinda call old school psychoanalytic psychotherapies. Psychoanalytic psychotherapies are more sort of like the big the big guy, Freud,
Sigmund Freud. So these are
Sigmund
the
Freud, yeah.
why tell me why are you so attracted to your mother sexually? Okay, that
Yes.
guy? All right. Or something along those there's always
Literally,
really?
literally. So then we learned why might that be the case and, sort of the theoretical underpinnings of that, and then from that, where, sort of the mental illness comes from, right? Like, how things manifest for the person, and then what's helpful in each of those theories. So there's the therapy, there's the theoretical underpinning which helps you to understand the human and the ailments of the human, the suffering of the human. And then also what are the interventions that we would use to help take the human from the ailments or the suffering to, um, feeling better or healing, depending on what you look at. So then, yes, in my program, there was like, okay, you kinda got to choose. One is, are you gonna go the adult route or are you gonna go the child route? Because
Okay.
there are differences in the way that we would treat adults and children, and actually there are differences in the way that we would treat children up to age 18, adults between the ages of 18 and 65, and then sort of after that, into older adulthood, that would be a different population with a different set of needs, a different set of circumstances. Because the other piece to keep in mind is that there are some physiological, neurological issues that can kind of come along, whether you're a child and you're in early development or you're in what we may call the geriatric population that have a different set of issues that might come up. You just have to know the differences and how to treat those things. And then another variation that comes along for psychologists in particular is that there is an additional group of individuals who go into psychological testing. So under testing or assessments, you also have a whole bunch of training that's actually really fascinating and aligned with what I do, but you have to learn how to assess for things like depression, anxiety, personality disorders. So cognitive issues. So if you're looking at someone who might have autism spectrum disorder, there's assessments that people take for that. If you have ADHD, if you're truly doing it correctly, then you should get an assessment or a battery of tests that a person would be taking, that sometimes they're extremely long, and you talk to a psychologist for many, you may take the assessment might take hours, and then there's an interview, and then they interpret the tests, and then they give you the results, and then they even give you recommendations on what you need to do next, the types of treatment you to get. For example, do you recall, this is kind of interesting, Rorschach
Yeah, the ink blot, sort of test, yeah.
testing? Yeah, so I'm actually looking at one of my Rorschach books right now, where I had to go and sit through an entire class where they taught us how to give that test and to interpret that test, um, and to how to score that test. So there's another aspect of it is scoring it, like, how do I understand why you, Vahid, saw a butterfly and I saw a ghost, for example? Um I'm sure the Rorschach people are kind of, holding their hands up like this going, "No, Pegga, don't! You're doing a terrible job of explaining that." But
No, you're doing great. So, okay, so we have you said the cognitive, behavioral, then you have the psychoanalytic, um, and then you have this other branch where it's assessments. So does neuropsychology fall under assessments? Is that
yes,
okay?
yes. So
Um,
neuropsychological testing, yep.
okay, awesome, cool. So
And then
there's
I
more.
think well, we said adult, we said children, and there's families,
Okay,
and
family
there's
thing.
couples.
Family therapy, couples therapy, okay,
Yep.
yes. Actually, I
So
think those are probably more widely known, right? So I think more people are familiar with, oh, family therapy, couples therapy. I've at least I'm familiar and I hear in regular conversation, you hear that, and just therapy as a whole is, people are familiar with it. But for example, you know, what you were describing is the psychoanalytical versus the cognitive. Those are the differences which I think that most people don't know. So maybe on a kind of a level, not too much detail that'll be hard to understand. But if you had to just parse out for the average person, what are the main differences between some of these widely used ones, the most popularly used, or maybe the ones with more evidence behind them, less evidence, and why? And when would you use each? What
yeah.
scenarios are they better in? Or any details which come to mind, if you kind of get my line of questioning here. Like if
Yeah,
someone were
yeah.
trying to figure out, like, well, what kind of therapy should I be getting?
So, actually, what does tend to make me feel a lot better is that when they kind of when they look at um, seasoned therapists or they look at the qualities of therapists across the board. Are There is a lot of overlap between a seasoned CBT therapist and a seasoned psychoanalytic therapist or psychodynamic therapist, or even a seasoned marriage and family therapist. You might be seeing a marriage and family therapist, but you're seeing them individually. For example, just because they have MFT or marriage and family therapy at the end of their name doesn't mean that they can't see you individually. And just because somebody might have only been trained in adults, it doesn't mean that they can't also do couples and families. But there is extra training that's involved. So it's not so much that I think what's your issue, and so go find that specific type of therapy. Now, definitely, if you're looking for a therapist for your child, find a child therapist. They are trained in a very specific way, and their background lends themselves to being able to do better work with children. The same with the geriatric population. Make sure that they have the training and the specialization in their background. Um, the same is true with, for example, you and I work together, right? And part of the reason why I enjoy working in this population is because I have a background in health psychology. So that means that I have a sense of, kind of the behavioral underpinnings and the issues and concerns that can come along with someone who has a primary health condition that then may manifest into depression, anxiety, um, all the other issues, that psychological issues that might come along. There's a whole world of, for example, psychological oncology or oncological psychology, I don't know. But,
Okay,
friends of mine who specialize specifically in the population of individuals who are struggling with cancer.
okay,
Um, so that's the I think the takeaway, I'm gonna just say it at the very beginning, is that it's not so much, what did you study in grad school? But what did you really put your effort and your attention in? And how did you specialize? I always tell this to my colleagues because I'm also a consultant. And yeah, you get the training, you get the background, you get the kind of the overall understanding of psychotherapy and assessment. I did a lot of assessment in grad school. Doesn't mean I do any of it today. So people should not be coming to me for assessments. I haven't done it in years. The last set of assessments that I did and that I, supervised was bariatric assessments. So that and still that was so long ago that I would need to freshen up. So I know enough to say this person needs to get assessed. Um, but otherwise what you wanna look at is what have they specialized in, what are they what's the population they tend to serve?
And, like, how would someone go about like, what I'm trying to get at is if somebody was interested in getting therapy, how do they learn who's the best fit
Yeah.
for them?
Yeah,
Or is it
yeah.
just trial and error, you're just gonna have to call a bunch of folks and see? Or is there, like, some kind of directory, or is there what's the best way for someone to say, like, "Okay, this is where I need to be?"
Yeah, so these days, thank goodness that, there are some great things with the internet, and one of those things is that there are these directories of clinicians who have been trained in these specific ways. So, for example, I'll talk about EMDR all day. There is the, EMDR International Association, and it's sort of a governing body that then um, has a sort of holds a standard for what clinicians should be doing in their practices to give them the title of this is a member of EMDRIA. We just call it EMDRIA for short. So in EMDRIA's case, are you getting continuing education in EMDR? Have you gotten hours of consultation in order to consider yourself certified? And then who are you getting it from? Like, I am an approved consultant in EMDR, which means that I had to go through training in order to become a consultant.
Okay.
So and then you can find, um, there are directories for example, for couples who are looking for someone who's trained in emotion-focused therapy. Now let me get clearer with you. So, going back to that, let's imagine it's an individual or a couple. They're looking for a therapist, and they're going, "Okay, thanks, Pega. Like, what do you want me to do with that information?" There really is this piece where you have to advocate for yourself.
Okay.
And I think you as a clinician can, can relate to that, right? I think
Absolutely.
all patients need to be their own advocate. They need to listen for whether they're getting what they're asking, what they're looking for, um, and to do some shopping around. So, yes, there are these directories. However, some clinicians aren't on these directories. Some clinicians are on your insurance panel. And so you're having to choose whether it's because you're going through insurance or there's financial limitation. You're looking at the people who are on your panel. Then it's even how far are they, right? And then I know thankfully post COVID, so many things happen virtually. Like look at the two of us right now, virtual. However, um, not everyone can practice across state lines. So you may go and do a Google search on an incredible therapist who you feel like aligns perfectly and understands exactly what you're going through and gives you even detailed information about how they could help you. But, they're in California. Sorry. Unless they're in what's called now I'm gonna even throw another wrench into it. Right now, there are these compacts,
Mhm. We have the
w
same. Yeah.
so interjurisdictional compacts where you can now the governing body has decided, okay, for psychologists, for example, like me, I can practice across state lines virtually.
Mhm.
So if I were to get someone from, let's say, uh, New Hampshire that wants to work with me, great. We can set up that time and we can make it happen. However, not everybody can do that. So back to the couple, back to the individual. Now you're going, okay, but still, which therapies do I use? That really is a matter of finding the right fit. And unfortunately, or fortunately, I don't know, both, um, it's not quite as cut and dry that, you know, um that this person has this kind of training and therefore they're gonna be great for us. Because like I said, the looking at therapists across the board, that some of them just have to have certain qualities that they bring into the room. Now, yes, we do get training around that. So it's not like we're some people are born with it, but some people actually have to get trained, like, what are you listening for? And how are you making those connections? And what do your interventions look like? What's the timing of your intervention? Is the patient available for it? So it's so nuanced.
So do you find that, like, when you receive a new client, that they've typically had several conversations with other therapists first? Is that, like, a really common thing? Where they're like, "Yeah,
Yes,
well, so you're the 5th person I'm talking to, this is what I'm dealing with, what do you do? How do you do it? What is EMDR, for example?"
yes.
And we can get into that. I'd love to at least get a general definition down for EMDR, um, CBT, DBT, ACT, the ones that you've taught me
My
about.
exam. Is this another
Is this
exam?
another example? Yeah, I
Yeah,
just
let's
wanna
do it.
kind of general, like, a few words about each type of thing. If you wanna start with, EMDR, since that's, an area which you spend a lot of time in and you're
Yeah,
certified.
but I will respond to what you just said
Yeah,
about
please.
the person who calls. Absolutely. I actually typically, the standard for our field, like if, let's say, for example, if you were seeing a patient, um, it's good standard of care to offer them at least 3 referrals. 3 realistic referrals, like, are they within their insurance panel or are they, financially feasible? Something that would be realistic. I mean, of course, these days, therapists can tend to be full, but, yeah, there's a little bit of legwork, and yes, even if somebody calls me and says, "Hey, I got referred by Doctor Yagana. I hear you're great. Let's talk." I'll usually say, "Try to shop around." Try to see before you sign up, see how this person talks about, how they approach what the issue that you're struggling with is. What's their approach? How do they understand what healing looks like? Um, Typically one question that I get that I usually don't give a very so certain answer to is how long before I feel better?
Okay,
So just so you know, like I'll be that therapist who will say, I won't be able to tell you that because I don't know right now. It will take time and we'll need to figure out what that time is. Now, certain therapies, like we were talking about the different types of therapies actually pride themselves on saying we're time limited. So, for example, some time limited cognitive behavioral therapies or even time limited psychodynamic therapy, psychoanalytic, more psychodynamic than psychoanalytic. Psychodynamic is an offshoot of psychoanalytic. Psychoanalytic is the Freudian sort of lay on the couch for many years, several times a week. Whereas psychodynamic gets more specific quickly. These are more symptom oriented approaches. So we're going to help reduce symptoms more quickly. And there are some that are time limited, like let's say 12 sessions. These are the types of therapies you might see in, for example, community mental health, hospitals, and like college counseling centers. Typically, college counseling centers these days have very limited treatment options for students, not because they don't want to, but the resources are more limited. So they'll say, okay, maybe you'll get 15 sessions a year, right?
okay,
So they do become very specific, very time limited. So you'll need to. They tend to use treatment modalities that are kind of focused,
okay,
like for example, CBT. What's the issue or the symptom that you come in with? How do we understand where this comes from for you? And let's begin with the interventions that will help you to sort of start to feel better. And then we sort of chart that. We take data every week to indicate, are you progressing? Are you moving along? How are your symptoms? Are they being reduced? And we compare that to the diagnosis. Diagnosis is specifically the, sort of the oh gosh, this feels like I'm back in exam world.
Am I giving you, some PTSD here?
Yes, yes, right,
Okay.
so number of symptoms, right, and the intensity of those symptoms, and the way that it impacts daily functioning. So, like, short and sweet, if I have depression, is it mild, moderate, severe, single episode? Is it in remission? Is it not? Sorry, I kinda got a little nerdy there. So just all the listener needs to know is that these therapists are looking at very specifically, um, where are you with your symptomology? Where do you need to go? And how do we know that treatment has come to an end? That is the time limited model.
So it has to be really well defined because
Yes,
of the circumstances. Okay.
yes. If you get out of that model, and where I work is more in private practice where there's a lot more flexibility. I also don't take insurance. I'm not on any insurance panels. What another word for it is out of network for with insurance. So that means that I will be now the good news, if you've never heard of this before, is that out of network is still a benefit in the insurance world. So insurance companies recognize that some people would prefer to go outside of the network that's defined provided for them in order to get care. And so in order to meet that desire and that need, they'll say, "Okay, you can go out of network, but your benefits are much different than what it would be in network." So typically, when I'm doing a screening call, I'm also asking about those things. Were you looking to use insurance? Do you have financial limitation? If you do, this is what it would look like for me. You would pay up front. I would give you a super bill, and then you would submit that super bill for reimbursement with your insurance company. And then I'll even give them codes so they can go find out from their insurance company what the reimbursement rate would look like if they were to come to me.
Okay.
Um,
So
See all
t
these
tell me.
rabbit holes.
Yeah, unfortunately, that's healthcare,
Yes.
in our environment, right?
Yeah.
You can't have that conversation without having an insurance conversation. Of course, you and I, have moved away from that, but it's still a large part of the conversation. For example, I order medications that, need to be covered by insurance, so I'm on the phone multiple times a day trying to justify things, like trying to, basically tell these insurance companies, "Hey, like, this person really needs this." And fighting that battle, which everybody in healthcare is familiar with, unfortunately. So yeah, it's part of the conversation. It is what it is. It's the environment that we work in. Um, Talking about more fun stuff now because I hate talking about insurance because it's not fun at
Yes.
all. Um, Tell me what EMDR is if you had to put it in a two-sentence answer.
2
I know
sentence?
it's yes. Do your best.
Okay.
Yeah.
I need to find all the commas and semicolons.
And
I've
EMDR
not
stands for, I'm trying to remember, eye movement desensitization and reprogramming? No?
reprocessing.
Processing.
Good
Okay, I was close, I
job,
was
good
close.
job.
Okay.
So we can even break that down, but the bottom line of eye movement desensitization and reprocessing is that there's a theory. So this is not the theory. It's the therapeutic modality, but the theory that underlies EMDR is called adaptive information processing. And it sounds fancy, but what it means, it's actually super cool when I think about it, that human beings naturally are inclined toward healing given the right circumstances. So the adaptive information processing model believes in that,
Okay.
in that given the right circumstances, what might have been an experience of what was a experience of trauma that maybe got stuck in the body in a certain way that then produced symptoms, either symptoms of trauma, anxiety, depression, relationship issues, um, just eating disorder, substance abuse, whatever that came out of it. Our task is to find the source of the trauma, and I'll explain what I mean by that, help to set up the circumstances around which that trauma can get reprocessed using eye movement or what we also call bilateral stimulation, which is the kind of the stimulating of the two sides of the body. And the understanding there, actually comes directly from the concepts around REM sleep, rapid eye movement. And so, Dr. Yagana, what is important about REM sleep? Do you know? I'm turning
That's
this around on
yeah.
you.
No, yeah, thank you. I love being put on the spot. It
Yes,
reminds
you're
me
welcome.
of all of my tests, and I start going to panic.
There you go.
Um,
Well, so here's where
memory
EMDR is
memory
helpful.
processing, emotional processing, so that's
Consolidating memory.
consolidating memory.
Uh-huh.
So yeah, REM sleep is pretty crucial for all of
And
that.
so
Yeah.
what happens during REM sleep? What does REM stand for?
Rapid eye movement.
So there you go. So rapid eye movement is what they understand theoretically is happening during rapid eye movement is what? Do you know?
Was what, sorry?
Why are the eyes moving fast?
And, I
REM
mean, that's
sleep.
when we're dreaming, but beyond that, I would assume we are, you know, we're going through all of these dreams and processes, and that's but I don't know the physiologic reason that the eyes would be moving around.
Yeah, so one of the things, that we kind of maybe make sense of is to say that, yes, you're basically digesting or metabolizing the residue of the day. So for when we do our dream episode, we can talk a little bit about that. So the residue of the day or um, any material that needs to be processed through.
I
You
like
know
the
how
term, the residue of the day, okay. That's
Yeah.
I
So you know how they say, "Don't make any decisions, sleep on it?"
mhm.
So this is why people say, "Don't make a quick decision, sleep on it," because the body is going to go through its own process with the material that it's been given, and when you wake up the next morning, you may feel differently about it, you may have new insight, you may have new awareness, um, this is typically I can go on, but why they say it's not good for a student to cram material, like study material and like not get sleep because sleep matters in the consolidation of memory going from short term into long term. So all of that is involved in understanding why EMDR can be helpful, and part of it is the REM sleep also helps to move memory, like the memory into like kind of the long-term memory into the file cabinet of the brain, meaning most memories are not really supposed to be that, um, consequential. They just get filed away. You know, like when we think back on like school. Okay, how many times did we get up in the morning and go to school every day, do our thing, come home, study for exams, and we're on repeat, right? Now, ask a person who was bullied how they held the memory of being bullied. And what you might hear is they'll say, I have a vivid memory. I have a very clear picture of the face of my bully. I remember being in the counselor's office crying all the time, so on and so forth. So now, you see, I want to kind of distinguish between a not so consequential, not such a big deal memory, and then traumatic memory.
So this is when the brain is deciding then, this memory I need to hang on to, this one I can file away, this is useful, toss this out. And so, what makes it about traumatic events that the brain goes, I need to hang on to this? Is this because we're wired to avoid danger or pain? And so that memory is useful from a survival perspective? I mean, I'm just theorizing. I have no idea.
Well, think about how you would understand an injury.
Uh,
Let's say I get a cut on my arm. The body recognizes that there has been a trauma,
mhm,
right? There's a cut on my arm, depending on how bad it is. Let's just not make it too terrible,
okay.
right? So I'm bleeding. There's a literal tear in the skin, and then the body immediately starts to want to heal itself, right? So the processes of the body is that you may get a fever because there might be an infection, so that's an indication that something else needs to happen, right? The fever is a good thing, right? The heating up of the body is helping to do something. I just don't understand it. But at the end of the day, I think what you wanna think about with traumatic events is that it's an injury to the system.
So I'm having something that's psychologically traumatic, right? So the cut on the arm was a physically traumatic.
Yes.
And yes, the blood is now starting to clot. The skin is already starting to, get to, okay, I need to close this wound, et cetera, et cetera. There's inflammation going on, all kinds of stuff. Um, what does that look like in psychological trauma?
So in psychological trauma, what you're experiencing is shock. It's a
Okay.
shock to the system. We have psychological needs. We look at the kind of a normally developing human. There's some needs that we have that need to get met,
Mhm.
kind of Maslow's hierarchy of needs. One of the needs is the need to feel safe, the need to feel secure, the need for predictability. Like, I know that, like, when I see you, when I walk in on a, Thursday morning, I'm gonna be met with generally, like, a kind of a positive demeanor. You might joke around with me a little bit, but my system is like, "Okay, safe. That's Vahid. We're fine. We're friends. We're colleagues." And in general, we have built this what's trust with each other, right? If I come in and I see that maybe you're on the ground and injured or something, I don't know what I would consider traumatic, but I could have a traumatized experience where my system, my visual system, my auditory system, my senses get they experience shock, like a no shit moment, right? Um, so if you imagine a kid being a kid, oh, this kind of breaks my heart. And then like a bully does something that's really shocking to your system,
Mm,
not to mention you're super vulnerable,
mhm.
right? Children are super vulnerable. Like this is why a big part of what I do, though I work with adults, I'm working with them
The kid
from
version of them.
childhood.
Yeah.
Yeah,
Mhm.
where the traumas occurred. Um, And this is what therapists understand is that this is a very, very vulnerable population that needs protection. And when they don't have it, these psychological issues can arise.
Okay.
So, does that make a little bit more sense?
Absolutely. Yeah, yeah, yeah.
Okay.
Okay, so there's this shock, and so the need of feeling safe, obviously that's not being met. What are the other psychological needs?
Okay, so five basic needs. Um, and this is where psychoanalytic theory, an offshoot of psychoanalytic theory is called object relations. They talk a lot about this. So, like when we think about normal or good enough parenting doesn't mean that parents have to be perfect all the time. Like parents can generally make a mistake or yell at their kid or not respond to their kid when the kid is asking them a question. It doesn't mean that the kid is going to be traumatized because it's a general pattern of experience, right? Like generally, I trust that my dad is safe. It's again need for safety and need.
I'm gonna help you out and cheat here a little bit.
Thank you.
Yes, Maslow's, 'cause, I actually, for those that know me, know that I absolutely love Maslow's hierarchy of needs. I've always been fascinated by it, but I can't remember it by heart, so I've pulled it up online. Physiological needs, and it goes, for those not familiar with Maslow's hierarchy, it goes from bottom to top. Like, I think of it as a pyramid. I don't know if that's how you're supposed to think of it, but I just think of it as a pyramid, and the base of that is physiological needs, right? So food, air, water, sleep, that kind of stuff, what you need to actually be able to stay alive. Next layer on top of that. So and then Pega, correct me if I'm wrong about any of this because I often sound stupid, but if I can help it, if you can help it, that would be great. Um,
Okay.
so that each of these levels needs to be met before the next one can be addressed. So if my physiological needs are not met, like if I'm out in the wilderness and I can't find shelter, water, food, it doesn't matter. The rest of these needs don't even hit my radar. I'm just trying to meet those first ones. So let's say those physiological needs are met, then I can build on that. And those are what you're mentioning, the safety needs, right? And that could be physical safety, kind of ties in a little bit with the physiological needs, but also could be, I don't know, a stable job, right? Like a career, those sort of like safety needs could be
Emotional safety.
emotional safety,
Emotional
especially in
so
the case of children, right?
children, exactly.
Um, the next layer above that would be like love and belonging. At least that's what. So social connection is how I would word that,
And
but
so
love,
in
right? Yeah.
psychological terms, for a child, you would say maybe there's, prizing,
Okay.
so the need to feel just that you matter.
Okay.
Like,
Prizing. Is it?
prizing is
Okay.
the word I think. The person that comes up is Kohut. This is, again, grad school. But talking about there's another word that they use, mirroring and prizing, being able to for a child to have a sense that there's a self and that they're valued, that they are a valued self.
Okay.
Um,
And
so
all of that falls in that same kind of layer.
yes.
Basically, what I'm calling the need for human connection. That
Connection, exactly,
okay.
and that's actually one too, right?
Okay.
To feel connect so when you think about, like, studies, all these studies that happened, that we learn in grad school of, like, lots of studies on, old school. If anyone's interested, I have a great book on it, where they looked at old school orphanages and how children were treated, very sterile. They didn't get held, infants didn't get held necessarily. They got fed, but they didn't get held, they didn't get soothed, they didn't get rocked. Now they recognize, like, when a baby is born, how important it is for them to have skin to skin contact with a parent. This is how early all
Mhm.
of those needs begin. Like, the not that thing those things not getting met really do create a sense of trauma in the baby. Uh, and there are actually phenomenal theorists now who look at working with children between the ages of 0 and 5, like, even in the womb, they're looking at what needs got met and didn't get met, and what issues have come along as a result. Yeah. Nothing I can actually talk about, but it's out there.
Yeah. No, I believe
Yeah.
that tracks. I
Yeah.
think I've read a few things about that in the past. I just can't remember specifics, but absolutely that. I mean, that makes sense. There's folks that remember things that early. I'm not one of them. I don't remember anything from being my babyhood, but there's folks that'll remember. Oh yeah, I
You do.
remember my mom's smell, or I remember
Yes.
this and things like
Yes.
that. So,
So I'll put in a plug here.
mm,
So if clinicians, EMDR clinicians, trauma therapists, we understand that that there are pre-verbal memories. So that means before you can even encode a memory verbally, which is how memories start to form. Either it's like, if I were to say, my family and I moved to the United States, when I was 4 years old and we moved to Tampa. I just gave you a memory. But really what it is, it's like this verbal information that I encoded as memory. Now, if you ask me to recall that time, especially at around age 4, you have that verbal ability by then. But 3, 2, 1, you have no words. So what it's really encoded as could be images, smells, like you said, or somatic body sensations.
mm, okay,
So, and this is where attachment work, like I do when I'm working with trauma and attachment, childhood attachment stuff, we don't always work in the realm of words and thoughts.
okay.
We work with body and body sensations because the body keeps the score. The body holds the memory,
Mhm.
but the body may not be able to file it away verbally.
So I'm missing 2 of these things. On my search here, it says that on top of those sort of love and human connection needs is esteem needs, so respect and recognition, and then on top of that, self-actualization, personal growth. Are those correct? Because I don't trust the internet that much these days.
Yeah, so you're using Maslow, but typically, for object relations theory or psychoanalytic theory, they'll there's overlap for sure. If I
Okay.
had my list, we can definitely see the overlap, but again, like, kind of feeling prized or valued, a sense of safety and security, um, like, and within security, I think is a trust, like, will my dad be there for me? Will my mom be there for me? And the ability to sort of see the pattern of, yes, they are available. But you said esteem.
Mhm.
Esteem is exactly what Kohut was talking about when you hold the baby or you look into the child's eyes and you lovingly feel big, huge, loving feelings towards the child, and the child is receiving that, and that gets internalized. So in them, when that's where self-esteem can come from, and then things can go awry. Um, another one that's really good and important is limits.
Okay.
So if a child, it's like kind of this balance between having limits, knowing what your limits are, and having freedom. There's this poor parents have to always know what the balance between that is.
I can relate.
Yeah,
Yeah, like, when am I being too
permissive.
permissive? When am I being too rigid and too
Yes,
helicoptery? And it is a delicate balance, I agree.
exactly,
Yeah.
and that's part of it too. So if you find too permissive, like the child is just able to run free and do whatever they want, there's a set of problems that can come out of that. And if you're too rigid and too militaristic, too authoritarian, however you wanna look at it, there's gonna be another set of issues that can come out of that. So those are the 5 basic needs. I don't even know how we started on the 5
No, I
needs.
love that. Honestly, we could probably speak a few hours on this because we had a general idea for this conversation, which was going to be let's walk through all the different kind of general types of therapy that are out there. But I feel like we can probably take EMDR itself and really parse it out because I find it fascinating. Maybe we can come back on an episode and just talk more about that in detail because I've always been fascinated about how it's actually healing, right? Like how
Yeah,
it's working. It's for lack of
yeah,
a better way to say it. And I'm starting to understand it from this conversation a little bit, at least sort of the way you tied it with, the dream state and rapid eye movement and memory processing, consolidation. uh, this is really interesting for me. So, and then hopefully at that time we'll have Adam around, and maybe you and a colleague or two that do AMDR can bring your insights. I think that's going to be great. But I know we are out of time. We've been out of time for a little bit, but yeah, I wanna pick
to
your
be continued.
yeah, I want to pick your brain a bit more about this, and so maybe another episode we could do that because I think it was a bit ambitious of me trying to talk about all of these in one sort of 45 1 hour minute slot. All right, well, I'm gonna let you off the hook.
Thank
I do
you. This is
appreciate
fun.
yeah, you sharing your knowledge and expertise, and I can't wait to talk more about EMDR the next time.
Sounds good.
All right,
Bye.
thanks for spending some time with us today on Take 3 and Call Me in the Morning. We hope today's conversation gave you something to think about. If you enjoyed the episode, consider subscribing, leaving a review, or just sharing it with someone who you think would appreciate it. If you want to learn more about us and our individual practices, you can check out Pega's practice on her website, livingfullytherapy.com. If you're interested in Adam's physical therapy practice, you can learn more about his practice on his website, equalizerhealth.com. And if you want to know more about my practice, you can go ahead and check us out at healthyconditions.com. Just a quick reminder before we go, remember this podcast is for informational purposes only, not intended as medical advice. So please talk to your healthcare provider about what's right for you. Until next time, and don't forget, be kind to yourself.